Good morning, friends. A warm welcome to our course on intraocular lens power. This topic has become quite important in the recent past because we are all aware today cataract surgery has become a refractive surgery, and we want to hit the bullseye, the target refraction in all our patients. Usually the target refraction is plano 6.6, and that is the holy grail. So with this in mind, we have devised this course. I'm Arup Chakrabarti, the senior instructor for this course, and I am helped and I'm proud to have the fellow speakers, Dr. Ramesh Durarajan from Chennai, Kumar Doctor from Mumbai, Dr. Nazneen from Kolkata, and she will be coordinating the flow of the talks and introduce the speakers. Dr. Prashobh from Kerala, right now he is in Trivandrum. Dr. Suven from Kolkata, and Dr. Meena Chakrabarti from Trivandrum. So nothing financial, though we'll be talking about few devices, there's nothing financial here. Now, after this introduction and my talk, then we'll follow this sequence of thoughts. Sequence of topics, we may not follow the exact order because some speakers have to go to other halls. We'll talk about Toric calculations, then we'll move on to secondary and piggyback intraocular lenses, the long and the short eyes, posterior segment pathologies and vitrectomized eyes, post-refractive surgery situation simplified, and then finally we'll have the whole session summarized by Dr. Nazneen with the take-home points at the end of towards the end of this course. Dr. Nazneen is a brilliant ophthalmologist. She did her MS from Aligarh, DNB, FICO. She had done a short-term fellowship in medical retina and long-term fellowship in glaucoma. Currently, she is the assistant professor in ESI Medical College in Kolkata. She had single-handedly established her glaucoma clinic in the hospital, has several presentations, review articles, posters, and publications to her credit, and has a keen interest in neuro-ophthalmology. So Nazneen, I'll just present my talk so that it will facilitate the subsequent flow. I'm going to make an unusual presentation in the sense that I'm just going to give you some take-home, some pearls, practice pearls, which I found useful to improve my refractive outcome over the years. And every year, these pearls change, the guidelines change, and this is what I practice today. What I have realized long time back, that IOL power calculation is just not a one-off event in the history of a cataract surgery patient. It is not something that use to tick off a preoperative checklist. It is an overall experience which pervades the preoperative, intraoperative, and postoperative period. Preoperatively, the bulk of the IOL calculation is done in this stage, but events, intraoperative period, and postoperative outcome also have important bearing in overall IOL power calculation. We first look at the ocular surface. Over the last couple of years, we have learned that an abnormal ocular surface can definitely have an adverse impact on the keratometry, the magnitude of astigmatism as well as all the axes of astigmatism. So whether you're planning for a toric lens or a non-toric monofocal or a multifocal lens, your results will go haywire if you have not taken care of the ocular surface. So after an ocular surface assessment, if the patient is found to have a deficient ocular surface, I would put the patient on treatment, optimize the ocular surface, and repeat biometry every few weeks till I get two acceptable and repeatable values, two consecutive on occasions. And I also believe in nil touch technique of biometry, where you do all the workup on a virgin cornea. So sometimes when you have done a cataract workup, Goldman apparition tonometry, pachymetry, gonioscopy after insulting the cornea with anesthetic drops, mydriatic agents, cycloplegic drops, the cornea is no longer pristine. So it is important that you don't do the investigations on the same day. Call the patient back on a mutually convenient day and do it. So I had sort of settled down into this practice pattern till last year when I saw an article which was very conflicting. So this showed that this was actually published in JCRS last year. After eye drops and Goldman apparition tonometry, there was no statistically significant change in the postoperative as predicted postoperative refraction as measured by the Lenstar optical biometer. Now, one swallow doesn't make a summer. So this is just one article that has come out. So I need more articles in the literature for me to have an evidence base if I have to change my practice pattern. So I do still, what I have told in the previous slide. I no longer dilate the pupils for my assessment. Two reasons, of course, I just mentioned, because when you put dilating drops, the cornea is no longer pristine. But another important reason is after dilatation, many studies have shown that there is an increase in the anterior chamber depth. And those multivariable formulas, as you mentioned here, which include the anterior chamber depth in the calculations, will not give you accurate results. So there has been some literature in the last couple of years. This particular study, published 2 years back, showed that after dilatation, the central corneal thickness and the anterior chamber depth show a statistical increase in the parameters. And it also showed, the same study also concluded that if you use the parameters obtained after pupillary dilatation, you are likely to end up with an IOL which will be 0.5 or 1 diopter more than what the patient would have actually received. So the study concluded that cataract surgery patients should receive biometry testing in an undilated state if you are going to use a multivariate formula. Sometimes we use artificial tears if the corneal tear film is not very adequate. Again, this particular study showed that, that this again has the propensity to change the corneal measurements. So you must wait, if at all you're using an artificial tear, you must wait for 5 minutes before you start your investigation, the corneal workup. And even the wait period may be even longer if it is a patient with ocular surface disease, or if you're using a very viscous kind of, tear supplement. The whole thing is the IOL power calculation field is very dynamic. It's a very happening. Every other month some new article comes up. So there are newer instruments and devices. There are formulas which have improved, and the lens constant optimization has also become quite important. Now this is what I do. I no longer perform a manual keratometry or autokeratometry, which is definitely a good thing. I mean, they give accurate results. So I measure the cornea using my optical biometer, and then I also perform a topography and eye trace for all my patients. And if the patient is on contact lens, then remove the contact lens couple of weeks prior to all the investigations. As regards axial length, we cannot still rule out patients where, all situations where axial length will be measured by optical biometer. So sometimes ultrasound biometry is done. And if you're resorting to an ultrasound biometry for whatever reason, use an immersion scan, because on applanation, if you use a contact procedure, the outcome is less accurate, and there is an average shortening of 0.25 to 0.33 millimeters. There are many naysayers which say that the optical biometry does not make any difference in real life situation, which is not so, because Dr. Hygis had shown in 11 review articles that what is the red bars that you see is the optical biometry, and it is much more accurate. So always use the optical biometer. And today we are spoiled for choices. We have too many optical biometers. So anything new that is coming up in the market, is there a need for us to upgrade? We have a lot of choices, even the basic optical biometers. So there I went through a couple of studies which showed that Aladdin and Lenstar give almost repeatable and results, and there is a lot of agreement. So you can afford to get any optical biometer which you feel is satisfactory from your perspective in terms of the vendor service support and things like that. Couple of years back, a BJO article compared IOLMaster 500 and 700. I still use IOLMaster 500, and it showed that there is good agreement between the two devices. Of course, the IOLMaster 700 gives you additional features and which may be useful if you're doing certain types of cases which are very less in number in the practice of an average cataract surgeon. So if you're using IOLMaster 500, that should be okay. If you cannot afford to go for IOLMaster 700. And using an optical biometer is not a guarantee to success. It is not some kind of a magic wand that you're going to get accurate values. So you have to validate the findings, all the variables, axial length, keratometry, etc. So there is a list available provided by the supplier. So that whenever you get a very inaccurate reading, that has to be deleted till you satisfy the validation criteria. Now for hard cataracts, a cataract like that, this is a patient I operated some time back, optical biometry doesn't work. So, but the fellow eye has maybe pseudophakic or it is an immature cataract, so optical biometry gives you a value. Then I would also perform an ultrasound biometry, and if in this eye, if the optical biometer and ultrasonic biometer axial length are more or less similar, I would assume that the technician has done a good job, and the axial length obtained by ultrasonic biometry is on the fellow eye, on the mature cataract eye, can be relied upon. And I also repeat it once more for confirmation. We do no longer use the older generation formulas, the newer formulas. Barrett Universal 2 is the go-to formula for me, and it is a suite. All kinds of IOL power requirements will be taken care of by this particular suite. Why I love it? Because it is absolutely free on the APSCRS website. It is accurate for all eyes regardless of the axial length, and you don't need to modify the axial length by Bangkok modification. A constant is already fed in a drop-down menu. In case you are using a lens where you don't have an A constant, the lens constant in this software, you can use the ULIB as A constant value or a manufacturer's A constant in case it is a new lens that you're going to start off with. Hill RBA formula also has been very promising. Recently, the version 3 was launched, and it has made it much more applicable. You know, it now calculates for a wider range of eyes, and it requires 4 to 8 variables. And Dr. Hill suggests that if you include all the 8 variables, the results are much better. The new kids on the block is the Cain formula, which calculates for non-toric, toric, as well as for keratoconus. And recent articles have shown that this formula is done very well in comparison with Barrett or Universal 2, Barrett 2 or Hill RBA formula. I always use multiple formulas in extreme eyes with extreme of axiom length. This was a post-ICL cataract, very high myopic eye. Patient had developed cataract, so I had to expand the ICL and had to perform a cataract surgery. So the traditional formulas gave me a power of 3 diopters after using the Bangkok axial length adjustment. On the other hand, Barrett gave me a 2 diopter. But here I went with the majority's opinion, implanted a 3 diopter intraocular lens, and post-op result has been pretty good. Intraoperative events are also very, very important. You have to make sure that your surgery is standardized, temporal clear color incision 2.4 to 2.8 millimeter, central 5 millimeter axis with anterior capsule overlapping the IOL optic surface. So we have to ensure, so this sort of reduces the error pertaining to the assumption of the effective lens position. This is the best we could do intraoperatively. Post-operatively is the moment of truth where you know how exactly you have performed, how far you're off from the target refraction, and then subsequently the lens constant adjustment may have to be done. I also use the experience gathered from the first eye prediction error in cataract surgery when I take up the patient for cataract surgery in the fellow eye. There's a lot of literature. This is an article from Barrett's team. So this adjustment issue is applicable when there is interocular symmetry, both eyes are similar. There has not been any refractive surprise. First eye prediction error is more than 0.5 diopter, and you have excluded other factors like transcription errors and IOL malposition. So adjustment coefficient of 0.3 or 0.5 has been suggested depending upon the formula that you're using. Say, for example, if you have a overcorrection to the tune of -2 diopters when you do on the first eye, so second eye when you operate, we don't set the target refraction as +2 diopters. If I'm using the Barrett, I'll put it as plus 0.6 diopter will be my target refraction. So even in fact, one of the latest formula, Pearl DGS calculator, also has a second eye enhancer. I have come to realize that gender plays an important role in the accuracy of the formulas. For example, the Barrett 2 is more accurate for the males compared to the females. On the other hand, the older formulas, formulas give more accuracy, more accurate values for the females. So friends, in conclusion, what I would like to tell you that I would like to take measurements on a pristine cornea. Measurement should be validated, work with properly optimized lens constants, adapt to new technologies as they present, but remember that any new technology may not give you a very significant advantages. Employ the right formula and strive to use all available resources to their best advantages. Thank you so much. Now I hand over the stage to Nazneen. Please introduce the rest of the speakers and other talks.
Welcome you all to this course on IOL power calculation. So the next speaker would be Dr. Prashab Mohan. He has done his MS from RIO Thiruvananthapuram, and currently he's the consultant in Cornea and Refractive Surgery at Girdhar Eye Institute, and he's also the medical director of Swarnam Eye Bank. And he'll be talking on Toric Calculations. Dr. Ramesh Dorairajan did his postgraduate diploma in ophthalmology from Shankar Netralaya, and he established and is the senior consultant at Sundar Eye Hospital, Chennai, and he has conducted numerous instruction courses in various conferences, and he'll be talking on secondary and piggyback IOLs. Dr. Kumar Doctor is the medical director of Dr. Eye Institute. He has been the past president of IIRSI, and he has presented several instruction courses in ASCRS and ESCRS, and he has performed numerous live cataract and LASIK surgeries. And today he'll be talking on the long and the short eyes. Dr. Meena Chakrabarti, ma'am has done her MBBS and MS from Trivandrum Medical College, and currently she is the senior consultant at Chakrabarti Eye Care Center at Trivandrum, and she is the winner of numerous awards, including the Best Video Award, Shankara Menon Best Paper Award. She is also the recipient of the National Award for Prevention of Blindness instituted by NSPB for the year 2007 for her work in preventing blindness due to diabetic retinopathy. Today she'll be talking on posterior segment pathologies and vitrectomized eyes, how to do IOL calculation in those eyes. Dr. Suven Bhattacharjee is the director of Nayan Eye Center, Kolkata, and he's also the director of MedInvent Devices, and of course he's the inventor of the BHEX pupil expander device. And he has received several awards, including the AIOS Shiva Reddy International Award and the International Hero Award at AIOC in 2007 and 2018. Today he'll be talking on post-refractive surgery situations simplified. So I'd like to welcome Dr. Prashab Mohan first. Okay, sir, sure. So Dr. Suven Bhattacharjee will be talking on post-refractive surgery simplified.
Good morning, everybody. Sorry for jumping the queue. I've got another presentation in another hall. So thank you, Dr. Arup and Dr. Nazeen, for this kind invitation. You see, when I was in school and before I joined med school, I thought I was good in mathematics and statistics. And when I joined med school later and did my postgraduation, I thought I was good at interpreting papers and studies. When it came to this topic, I realized that I'm a dumb guy. So, and Arup rightly allotted this to me so that I could keep it simplified, as much as I understand. So if you can understand that much, I think that's enough to go on. And thereafter, you have people like Ramesh, Dr. Arup, and Nazneen, Prashab. They will kind of guide you to the higher level. So I'll keep to the basics as much as I understand. So now a quick revision. If you make biometry errors in these three parameters, axial length, 1 millimeter error gives you a 3 diopter refractive error. Keratometry, 1 millimeter, 1 diopter, and AC depth, 1 millimeter is 1.5 diopters. So you can choose which one you want to make your errors in, and you can go ahead. So the problem with refractive surgery is standard keratometry methods don't apply because the corneal curvature has been altered. The standard formulae don't apply because the corneal power was based on your Virgin's calculations use the corneal power, and it's also used to I think predict the ELP. So with any system, if you put garbage in, you're going to get garbage out. So that is the problem with the refractive surgery. All your earlier measurements are practically garbage. So when we're talking of post-refractive surgery, we have LVC, that's LASIK, PRK, SMILE, LASIK, for myopia as well as hypermetropia, and we have RK. These are two different animals altogether, and they behave very differently. So now we come to the keratometry problems. The first problem that we have in LVC is that they modify only the anterior surface. So entire calculation was based on a fixed ratio of the anterior and posterior surface of curvature. So once the anterior surface is modified, you got everything going haywire. So now the posterior curvature was extrapolated based on the anterior curvature, so that entire thing is not valid now. In radial keratotomy, again, what we have is You may still maintain a fixed Gulstrand ratio, but then you have a smaller optical zone. So that's kind of another different game now. And then you have diurnal variation, long-term drifts because of the alterations in the cornea itself. Now, there is another problem with keratometry is the radius zone error. So what it means is basically in automated keratometry, what we used to do is we measure 3 to 3.2 millimeters, whereas in myopic LASIK and PRK, it's producing a larger optical zone, and hyperopic LASIK or RK, it's quite the reverse, so we're getting a smaller optical zone of 3 millimeters or less. So now these are the three things where we need to see the difference between the LVC and RK. So in a normal cornea, the spherical curvature is assumed, the anterior and posterior curvature have a fixed ratio, and you have a standard optical zone. These are the basic guidelines, three tenets on which everything is based. Now in RK, what happens is, it's a flattened cornea centrally. The anterior and posterior corneal curvature may still be maintained, as I said, but the optical zone has been reduced. So, and the refraction will change to add insult to injury over time. In LASIK or PRK for myopia, if you look at this thing, so what has happened now is the anterior curvature is flattened. The anterior posterior curvature have got no relation now, and it's a larger optical zone. For hypermetropia, it's very much like the reverse. So you have a steepened anterior curvature. Again, that's not maintained, the ratio, and you have a smaller optical zone. So this is kind of all sorts of permutation combinations you have over here. Now, ELP, the IOL calculation formula may differ in any way, in whatever way, but they do use the corneal power in assessing the ELP at some point in time in the formula. So if you have a myopic ablation, the formula incorrectly assume that the antechamber is shallow, so you have an anterior ELP and underestimation of the power, and you have a hyperopic result. So now the workaround or the remedies for post-laser vision correction is directly measure both anterior and posterior curvature, and thereby you get the net corneal power. So now you have the real corneal power. In post-RKIs, you have to take into account the optical zone also. So now K readings solutions over time, now corneal topography has been used, Scheimpflug photography has been used, and OCT has been used. Different machines have integrated it differently. Now there's something you must understand that there are terminologies which are very similar. SimK is one, okay, does not confuse it, measures within the 1, 2, and 3 millimeter zones. Scheimpflug uses simulated keratosis, that's SimKs, and there's something called EKR, the equivalent K reading for holiday. We'll come to that a little later. Now there's something called total cornea power, or the true net K, or the true K. That's a software calculation. It's different from what the Zeiss Master 700 does, and that we'll come to that later. So, and OCT is another way of measuring the anterior posterior, the thickness of the cornea. Apart from the axial length, we measure the thickness and put that into the measurement of the corneal curvature and factors. It kind of enhances the accuracy of your. So EKR, if you look at it, if you look at post-RK eyes, if you look at the variation over here, within the same 4.5 millimeter zone, the variation is almost 12.7 diopters. So that is what needed to be taken. But this is now not relevant so much because the other formulae have taken care of this. In post-LASIK, that variation is much less. It's 3.3 diopters in the same 4.5 millimeter zone. Again, this is a more of historical interest. So if you go to the K reading solutions from biometers, the LS900, it's got 32 reference point, 2 circles. You got all that in the literature. IOL Master 700 does something good. That's total keratometry. And that's something new. So if you are having, I think Ramesh over here will be much better to guide you. I think you have a 700, Ramesh, do you? You have a 700? Yes, so he's in a better position to guide you on that. If you're having a lot of post-refractive surgeries, cataract, I think that would be though I have no financial interest and I don't own one either, so, but that would be the one to go for. And I do have a Tomy OA2000, works good for most of your cases, but post-refractive you have to be a little careful and maybe a cross-checks here and there. So in the Tomy, what it does is does topography simultaneously at 2, 2.5, and 3 millimeter zones, and it's got 9 Myers, so it gives you a fairly good idea, but it's mostly topography. So IOL Master 700 has brought in something called the total keratometry. Now, this is basically telecentric keratometry, measurement of the anterior corneal surface, And swept source OCT directly measures the posterior corneal surface and the corneal pachymetry. So it's basically swept source OCT doing all that. So, and you got multiple points. So it gives you an equivalent K, which enables you much better to calculate the standard IOL powers. Now, this is a post which I have taken from Dr. Ramesh, sir. So this is on social media post. Ramesh, I'm referring to your social media post. There's a social media post from you. So this was there, and I found this very useful. I think pretty much sums up. His concepts are pretty clear on this. So a stray social media post kind of caught my attention and pretty much sums up, your choice of keratometer post LVC eyes. So if it's a regular eye, manual K, auto K, optical, all are pretty okay. But if it's unusual, like the post-LASIK, PRK, or keratoconus, about 1 minute more? Yeah. Okay. So the true K values from 700 anterior, any OCT or Scheimpflug-based device are in that order of priority. And if it's a post-RKI, where the corneal thickness is not altered, but the central K is different from the flatter paracentral K, it's Zeiss topo or OCT-based and or auto K, optical K, and manual K in that order. So if you should know where you stand vis-a-vis your keratometer readings. So formula solutions have been either correcting the formula or the results. It's fudging one of them. Okay. So Barrett True K formula gives us based on its Barrett U2 and calculates a modified keratometry. It requires measured keratometries and refraction values before and after laser. But see, these are all more theoretical, so it takes care of all these 5 formulae. Now, what I wanted to say is, in this particular paper into 2020, it was found that the Barrett True K provided the lowest mean refractive prediction error. So that way, that is some evidence that we have. And this one, again, formulas combined with TK achieve similar or better results compared to coexisting no history or post-myopic laser refractive surgery formulae. This is, I think, a go-to place for most of us where we go, and of course, people who discern a lot more do a lot of other things. So these are standard tools where you can use it for myopic, hyperopic, post-RK. You input the data, and the best thing is it gives you results based on how much data you input. The more variables you fill in, the more accurate your results are likely to be, and you get calculations based on there are various formulae that it kind of gives us, the ASCRS platform, and it gives you various. So now you can compare and contrast and see how many, and if you would like to go on and refine that by adding a few more of the variables. So the same, so myopic classic and with prior RK, again, the same thing. You can fill in arbitrary formulas and get figures, and you can see that's how you get. So my recommendation would be it's history and counseling, consent. I think it's absolutely paramount that you might have refractive errors of different ranges. And if you can, you get true or total K values. Optical biometry is, of course, the order of the day. Target post-LASIK, post-RK target minus 0.5D, and post-RK target minus 1D. So the consensus and recommendation of corneal power and calculations are constantly changing. Thank you very much for your attention. I hope I've kept it simple.
Since Suven will be leaving for another hall, so if there are any questions for him, he will take them. Yeah, or we can take up the questions later on. If Suven, you can come back.
I have one question. You had said on your post that post-RK, corneal thickness is not altered, so you would prefer a Zeiss topo or an OCT-based system. So,
Mic is not on, no?
you can use any one, right? You don't need to use, you can even use a method.
Yes, you can. You just need to have a very small any measurement of a central small zone, like 2 millimeters or so.
But the flattening area that happens in RK can be from 2 millimeters to 3 millimeters to 4 millimeters. But you are worried about the central 3 millimeters.
Or less.
Or less.
The smaller the zone you measure, the more likely you are to be
so you are
accurate.
suggesting in post-RK take the K reading from the pentacam?
Yes.
Or whatever topography.
Whichever will give you the central 2 millimeters or so.
Oh.
Not 3 millimeters
But the
and
new
more.
optical biometers also do that, right?
Yes.
They are more accurate, in fact.
They go larger.
No, I'm using Anterion, and Anterion measures.
Anterion is also a topographer. it gives the
Like TOMI allows
Yeah,
it gives the different zones readings.
yes.
TOMI allows you to calibrate the zones, you know, how much you want, whether you want 2, 2.5,
Smaller zone.
yeah, smaller zone. Right, thank you, Ali.
Okay, yeah, thanks a lot, Suven. So over to Prashov.
So hello, thank Dr. Arup for giving me this opportunity again. So we're talking on toric IOL calculations, no financial interest. Now, why do we want to implant a toric IOL at all in the first place? It's because it's been found by many studies that roughly around 1/3 patients undergoing cataract surgeries have significant astigmatism of more than 1 diopters. About 20% have more than 1.5, and 8% have more than 2 diopters. Of course, toric monofocal IOLs gives a better uncorrected distance visual acuity, and when it comes to multifocal IOLs, they have very little tolerance for astigmatism. So it needs to be addressed using a toric IOL. The prerequisites for a toric IOL calculation are have been told by Dr. Arup before itself. I'm just going to repeat it. The ocular surface and the tear film are of paramount importance. And I would always suggest, if you have access to a topographer, even a placido disc-based topographer, to do a topography before you plan on a toric IOL, rather than just Catarametry. Because the topographer gives you a better idea about irregular astigmatism, and it does not just tell you about meridians. And when you have irregular astigmatism, your planning kind of changes. That I'll explain later. And of course, axial length has to be accurately measured, preferably with an optical biometer. If not, a good ultrasound biometry with an immersion technique will also do. And for keratometry, we have several devices available nowadays with us. And if you have more than one device with you, I would suggest take readings from both the devices. And if you have only a single device, take multiple readings. There have been several advances in determining the corneal power. And there are various devices. This is not an exhaustive list. There are n number of devices which can measure the posterior corneal power and determine total corneal power. Some of them are the Galili, the dual Scheimpflug camera, the Cassini, it's a color LED topographer, and the total keratometry from the IOL Master 700. These are the main ones on which studies have been conducted, and they have shown to be reasonably reliable in predicting the total corneal power. And other considerations for toric IOL calculation are pre-existing astigmatism, your surgically induced astigmatism, and the presence or absence of irregular astigmatism. Pre-existing astigmatism, we of course get it from the keratometry. Surgically induced astigmatism, we are not that bothered about nowadays because Dr. Hill has provided us with the SII calculator, and it has been found that for most of our surgeries, sub 3 mm incisions, the value goes around between 0.8 and 1.4. Posterior corneal astigmatism was formerly considered insignificant, but now cataract surgery is a refractive surgery. And earlier we used to have a number of patients who have an error of about 0.72 to 1 diopter. Nobody knew where it came from. It was thought to be caused by IOL tilt. But now we know that posterior corneal astigmatism is important, and it has an average about 0.3 diopters, and mostly doesn't change with age, unlike the anterior corneal astigmatism, and it goes in the against the rule direction. So if you do not consider it, it can lead to overcorrection of with the rule or undercorrection of the against the rule astigmatism. Now, there is an important question here whether we have a reliable enough instrument to accurately assess the posterior corneal astigmatism for toric IOL calculations. Now, this situation is significantly getting better every day, that we have better instruments to calculate posterior corneal power. However, all said and done, the regression formulae, such as the Baylor nomogram, the Abulafia-Koch formula, and the Barrett-Toric calculator, have consistently shown that they perform as well or even better than the instruments that measure the posterior corneal power, using nomograms that calculate the total corneal power from just the anterior keratometry. So this has been a battle between statistics and actual measurement of the corneal power. So far, statistics have been winning. The Baylor nomogram is a nomogram which you can obtain, and it usually calculates the toricity at the corneal plane using a Holiday 2 formula. You should factor in your surgically induced astigmatism, apply the nomogram. It tends to leave some with the rule astigmatism. There is also the Abulafia-Koch formula available on the Toric Calculator online. But this is the most popular and the easiest formula to calculate IOL power for toric IOLs that is available nowadays. It's a Barrett Toric Calculator available for free on the ACRS website. And it has more or less outperformed all other methods to measure posterior corneal astigmatism or matched it. It calculates the spherical power using the Barrett's Universal 2. And there is also the option of entering the measured posterior corneal astigmatism using any of the instruments that I mentioned before. You can enter a measured PCA, or you can let the nomogram calculate the posterior corneal astigmatism by itself. These are the new kids on the block, the Cain formula. Cain formula has been found to have similar outcomes as the Barrett Toric Calculator, and it also has an optimization for keratoconus, which may be very important. However, I would strongly encourage to consider and think twice before implanting a toric IOL in keratoconus, only if it is a central cone and if it's a reasonably regular astigmatism, and if your manifest astigmatism and the keratometry are matching, only then go for the toric IOL in keratoconus. And don't go for toric IOLs in keratoconus if you think the patient will continue to wear RGP or scleral contact lenses after the surgery. Evo-toric formula, that is the emmetropic verifying optical formula, is the latest one. It uses a thick lens modeling and theoretical prediction of the posterior corneal astigmatism, and its performance, according to some studies, has been found to be similar or in accuracy as the Barrett Toric Calculator. Now, surgical induced astigmatism was a big deal some time before. It is the change in power of both the change in power and the meridian of the astigmatism after the corneal incision. It depends on various factors. The corneal SIA depends upon the incision location, size, architecture, radius, thickness, rigidity, the stretching of the incision as the folded IOL pass through it, the biological response of the cornea. Corneas with greater hysteresis have lesser SIA. Then there is also the lenticular SIA. There can be IOL tilt that can produce a surgically induced astigmatism. So to prevent that, you make sure you have enough coverage of the anterior capsular rim around the optic of the IOL. And depending on the AC depth, the predicted AC depth is more or less than, if the actual AC depth is more or less than the predicted one, you can have a difference in not just the spherical path, but also the toricity. And remember that average SIA may not be the same as the SIA in the next case. However, there's very little that we can do about it. So the SIA has been shown by Dr. Hill to be not changed too much. And the vector analysis of SIA has been a game changer. And according to the centroid values, the mean, it is a two-dimensional value of SIA for a series of patients. And it has been seen that for sub 3 mm incisions, it ranges from about 0.08 to 0.14. So if you don't bother to calculate SIA also, you can just key in as the value of 0.12 if you're doing a temporal clear corneal incision. Or you can calculate your own SIA by going to the website, siacalculator.com. There are various image-guided systems, Verion, Callisto, IOL Compass, Zaldivar, Toric Caliper. They help in reducing the parallax and transcription errors while you transfer data from one instrument to the other. There are a number of online tools. This is not an exhaustive list. There are various number of tools that you can use, apps and online tools using mobile phone photography. And there is also intraoperative barometry, which performs an aphakic and pseudophakic refraction on the go while you're operating. The ORA with Verify is the one that is popular. Holos Introp, I do not think is manufactured anymore. And it guides the surgeon, gives the direction in which the IOL has to be dialed during surgery to achieve emmetropia. Post-op analysis is important. See how your cases do and what has gone wrong and what can you do to make it better. Does it require an IOL exchange or is a simple IOL rotation enough? For that, astigmatismfix.com, recalculatortoric.com, and the Barrett's RX formula are useful. So to sum up, the keys to accurate toric IOL power prediction are accurate keratometry. You have to pay attention to the basics, the ocular surface, rule out irregular astigmatism, do a topography if possible, as much as possible. Make sure you're positioning the head properly while taking the keratometry. Take multiple readings, see if they are in agreement, use multiple instruments, and of course use modern formulae. Thank you.
Thank you, Dr. Prashop, for the wonderful presentation. Our next speaker is Dr. Ramesh Dorairajan, sir. He'll be speaking on secondary and piggyback IOLs, IOL power calculation.
So I think we'll pool together questions. Let all the talks be over, and then if there are any questions from the audience, we will take them up. So that way we will be able to keep to our time limits. If you want to, you can just jot down the questions and send the questions to us.
Thanks, Arup, for asking me to talk about secondary and piggyback IOLs. So the location of the secondary IOL can be in the anterior chamber, front to back, retro iris fixated, sulcus in the bag, or it can be scleral fixated. Piggyback lenses are usually in the bag or in the sulcus, so it's a more easier proposition. iWiki says that the reasons for secondary and piggyback IOLs are these, but for most of us, number 3, after complicated cataract surgery, forms the bulk of our reasons for putting an implant. We have a surgery where we have complication, we have PCR, and we tend to postpone, and then we do it. A good friend of mine who has a large volume teaching program for postgraduates, who does somewhere about 8 to 10 secondary IOLs every week, tells me that if you're not prepared, if you're not experienced or prepared and don't have the proper equipment, please don't rush and put a secondary IOL. Tell the patient that half the surgery has been done, cataract has been removed. We'll put the lens and wait for the cornea to clear, wait for the eye to settle, and do it anywhere 3 or 5 days later. So don't rush with your secondary IOL, and he gets very good results. So this is a take-home point. Tell the patient half the surgery is over, and you'll do the remaining half when the eye clears up a bit. In the Western series, the commonest causes are incorrect IOL power, IOL luxation, opacification of IOL, photopsias, and dissatisfied patient with multifocal IOLs. In this large series from Greece, they found that 75% of the secondary IOLs were for IOL dislocation, around 20% was for aphakia. This group is a group which had surgical complications and the patient was left aphakic, and 6% was for IOL opacification, something which you don't talk about at all, but that people are explanting foldable IOLs because they become opaque. Primary piggyback IOLs is done when we don't have a lens with enough power in severe axial hyperopia. This was common earlier, but now with most manufacturers making very high power lenses, it's not really an issue now. Secondary piggyback IOLs are usually implanted for post-op ametropia, and the options include monofocal, and we also have toric and multifocal options, and these are hydrophilic lenses which can be slipped into the sulcus over the initial intraocular lens. So secondary piggyback lens is usually done for a refractive purpose. Rarely, secondary piggybacks have been done in small series for severe negative dysphotopsia with reasonably good results. The best location for a secondary implant is obviously in the bag if you have sufficient bag, and or in the sulcus. The other options that we normally have to resort to are AC, iris fixation, and scleral fixation. Most studies show that no one method is superior to the other. But this particular series from Greece does show that you have more chance of losing 3 or more lines if you are fixing it if you are doing a scleral fixation. And these tall lines, if you put it in the anterior chamber, the clear one, if you put it in the bag or in the sulcus, you have more chance of getting three lines or more. So how do you calculate the power in these different locations? For in the bag and scleral fixation, please use your normal calculation. If you're going to put a sulcus implant or an iris fixated IOL, calculate for the bag, and then you have to adjust as per the following table from Dr. Warren Hill's site. So most of our patients are going to have between 17 and 28, so you just reduce 1 diopter because you're shifting the plane of the intraocular lens slightly in front. If you have a very high plus lens, like a plus 28 or more, you have to reduce bag calculation by 1.5 diopter. If you have a highly myopic eye, the calculation for the sulcus, the iris fixation, and for the bag will tend to be the same. So less than 10, implant the same lens. This is the rule of the thumb. For AC IOLs, just go and use the manufacturer's A constant. So for piggyback IOLs and for aphakia, the ELP tends to change depending on the location of the lens. And the refractive divergence calculator from Warren Hill site, this is actually very easy, though it looks very, very complicated. All you have to enter is the K1, you have to enter the K2, and you have to enter the preoperative power. So if you have a patient who accepts 3.25 for plano, and you want a post-op minus 0.25, it will give you a power of 5. So you just have to know K1, K2, and what the acceptance is to use the refractive divergence calculator. It's not complex. There are clear instructions. Please go to Dr. Hill's site, and then he'll tell you how to do it. For most secondary IOLs, the go-to formula is what Dr. Arup told us in the beginning during his talk. The Barrett suite of formulas also has a outcome analysis, or the Barrett RX formula. Here, please see the top. You have the patient data on top. Okay. By the side, you have the next option, if you want to exchange the lens, and then you have the piggyback lens formula. So this makes it very, very simple. So you enter your usual K1, K2, and your axial length and the power that you have, and it will tell you whether you can rotate your current intraocular lens or you have to exchange it. So here is an example of a 82-year-old physician who had lens implant done by a good friend of mine. He had 6/9 vision through a small zone there. He had 6/9 vision, but he wanted to read the Hindu and the whole lancets. So he wanted to have better vision. So I did cataract in the fellow eye, because the fellow eye had a simple cataract. But then after the fellow eye was done, he still wanted something to be done for this eye. And here you can see that he has a little bit of vitreous peeping through the small PCR here, which has caused and then the previous surgeon has put a nice lens in the eye, but he has severe fibrosis and upward dislocation. So in this particular patient, I removed the lens, did an anterior vitrectomy, and then did a scleral fixated lens using a standard calculation. And here you can see the scar of the Hoffman pocket, which was created. And the iris hooks were used, so the pupil has become a little larger, but basically he got 6/9 uncorrected and is reasonably happy. So here is one more patient who had surgery done several years ago. I think it was about 15 years ago, and she had a +8 pre-op, and the initial power that I put was not sufficient, so I put a piggyback lens in the eye. She came for a review 2 or 3 weeks ago, so I took this movie, and these are 2 PMMA lenses from Appasamy Associates, and she's quite happy. But this reason, that is high ametropia and inadequate lens power, is not really needed now, because we get very high power very easily. So in summary, use the Barrett RX formula. Also think of the refractive divergence formula from Dr. Hill, and custom powers for extreme hyperopia is possible now, and please consult your local IOL manufacturer. Thank you.
Thank you, sir, for the wonderful presentation. Our next speaker is Dr. Kumar Doctor, and he'll be talking on the long and the short eyes.
Good morning to you all. I'd like to thank Dr. Arup and Nazneen for this opportunity given to me. I'm going to talk on optimizing IOL power calculation in long and short eyes. I have a little video. I would like to thank Dr. Shivani, who is my associate, to have helped me compile this presentation. I'm just going to give 2 examples and then show a little video. So this was a patient with 55-year-old post-myopic LASIK, had nuclear sclerosis, and planned a multifocal IOL. So do I do multifocal IOLs for post? They are very demanding, and I do them, yes, there is no doubt about it. So here I'm showing the new readings from the Anteron. It's an optical biometer made by Heidelberg. I was very impressed, and I ultimately decided to go ahead with this technology. How does it help me? So this is the axial length measurement, that you have a 24.29, ACD of 2.63. It also gives you lens thickness, which is an essential part for expected lens position. keratometry, and white-to-white diameter. So we go ahead and do this. Now, according to the Barrett True K, we got a 22 as a minus 4.27. According to the calculations on the anterior, of course, we got the same reading. So you saw that 22 is 0.16 and 22.5 is 0.18. So these were the two readings that I got. Now, I also got IOL master reading done. So when they are post-refractive cases, I prefer that I do an IOL master. I compared it with the anterior to conclude what's happening. I also did the ASCRS calculation. So the ASCRS calculation on IOL master was 22. ASCRS calculation using anterior readings was also 22. So I went ahead and stuck to the anterior reading because that's what I have. And my patient went ahead with a successful trifocal synergy IOL with a 22 diopter, and the post-op was 6/6 part with an N6. The autoref showed that. All of you know that autoref is not very accurate as far as multifocal IOLs are concerned. As far as a short eye is concerned, a hyperopic patient with a very, very shallow anterior chamber, and the patient wanted a multifocal IOL. So you can see the short, small anterior chamber, a peripheral iridectomy, which is caught on the anterior segment OCT from the anterior. Here, the axial length is 21.30. The ACD is 1.92. The lens thickness is normal, as you can see, 4.37. Keratometry and a white-to-white, which is small, which is 11.5. So went ahead here in this case, again I did a Hill RBF. So at our center, we use the Barrett, the Hill RBF, sometimes the SRKT, depending on the axial length. So we do 3 formula calculations for each eye. And here you can see that the Hill RBF said to use a 31.5 on the anterior. With the Barrett, I got the measurement of 31 as 0.03 and 31.5 as minus 0.35. So this is what I got on the anterior. I'm just showing a little bit of the surgery here. Very, very shallow anterior chamber. I had performed a Z8 femto, made the incisions with the laser itself, picked up the rhexis, went ahead and did phacoemulsification. Now, very surprisingly here in this case, I found that in spite of clearing a 4.37 lens, I did not find so much space as far as the IOL was concerned. And here I'll show that I'm doing bimanual IA. After a femto, the bimanual IA is almost a little different than the normal IA where we get. So here I'm implanting a 30.5 diopter IOL. You can see that 30 with multifocal IOL. So going ahead and placing the IOL in the bag. Once this goes in, just make sure that it's placed horizontally. We got Virion technology, so we are aligning the toricity of the lens, which is at 6 diopters, then removing the viscoelastic from the front and back. So here, a very, very shallow anterior chamber, you have very, very little space of 1.92. So a Technis multifocal, a 31.5 with an add of 3.25, and we got excellent results. So this was a short eye, very small anterior chamber, but we got very good results. Now, one case I'll show you, some of you may have never seen this. Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in 2 cases, extremely short axial length and a small ACD, namely the non-ophthalmos and... No, you can keep it on, but can you reduce the volume? Keep it on. With high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea in a very shallow anterior chamber, and corneoscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes. A detailed imaging was performed on tomography, optical biometry, and a corneal wavefront and an ocular wavefront analysis was done. What the test revealed was indeed unique and surprising. Her white-to-white diameter was 10.7. Her ACD of 2.68 and her lens thickness of 4.27 in both eyes. Her axial length in OD was 14.85 and OS 14.89. Her
patient taken up for femto, plexus and a 4-quadrant division of lens performed. A 0.75 millimeter side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrhexis forceps, the CCC was grasped out. Bimanual IA used for aspirating the lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed. Post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20.
So this was a nanophthalmic eye, and Hoffer-Q is the formula that works the best in my experience with such extreme cases. We had one more case, but because of paucity of time, I won't show that. But in long and short eyes, optical biometry is, I think, an essential tool besides immersion. So I know that, as rightly mentioned by Arup, that according to me, contact biometry should be banned. And it's not very expensive to shift from contact to immersion. I agree that optical biometers are expensive, but it's a wise investment because your accuracy will give you results, which will give you a return of money, etc., etc., etc. So this was 3 examples. Thank you very much, Arup.
The well-documented cases and the videos. Our next speaker is Dr. Meena Chakrabarti. Ma'am will be talking on posterior segment pathologies and vitrectomized eyes.
So Kumar, your cases were very well demonstrated. So what I just wanted to convey is, we have sorted out the problems with high myopia, with the optical biometry and the advanced formulas. That is actually no longer so difficult for us. But the problem with the short axial length still exists, the getting which formula to use. Hoffer-Q, worked well for you, but I would suggest that if we use multiple formulas and then see the amount of agreement between the formulas, and then take a call and tell the patient that we may require a secondary intervention. What do you say, Ramesh?
Totally feel the same, that these short eyes are a big problem. There's a 2022 review comparing the various formulas, which show that if you use Barrett and if you use DGS formula, these tend to give you the best results. So the Pearl DGS is a new formula which has come. It is made by Getaniel and group.
Yeah.
So we can expect to see some kind of a clarity in the next 2 years or so.
Okay.
Only thing was that in the Barrett, it didn't accept a 57K. It said beyond normal limits,
Right.
it wouldn't accept.
Right.
So I got stuck at that level. I have no experience with the other formula you mentioned.
Right.
So as you saw in this case, I have done all the calculations, including, and I got a range from 49 to 65. So there is no agreement amongst all this. But luckily I went with instinct and
Yeah.
talked to a lot of people, and they said, in short eyes, Hoffer-Q works the best.
Yeah. Use the phone because we are recording all the sessions, all the speakers. Yeah. Can you repeat?
So
Yeah.
I got, because of the 57K, many IOL calculators did not accept a 57K entry only to do the calculation. So that is where I was getting stumped, and I couldn't go to the next level only because they say beyond normal limits and it stops there. That was the problem I faced.
Dr. Kumar, your patient is doing extremely well. So Hofacute
Yeah.
has worked for you.
So retrospectively, it was a good conclusion.
Yeah.
But I feel the future generation of doctors will be tending to use Cain and Evo formula. They'll be using the current generation formulas.
I mean, if you speak to the established gurus in IOL power calculations, they say Hoffer-Q belongs to an older generation, and as Ramesh rightly mentioned, that Cain formula, Evo formula, maybe are the formulas to look forward to.
Good morning, friends. At the outset, I'd like to thank Arup and Nazreen for giving me this opportunity. We are looking at a subset of eyes who undergo cataract surgery, who have a compromised posterior segment. They must have undergone prior scleral buckling, vitrectomy, or a combined procedure. They must have had a silicone oil or a gas tamponade in the eye. And please bear in mind that we are not looking at a target refraction of 6 by 6. These are compromised patients. So we would like to put in all our efforts to optimize the IOL power calculation and give them the best possible visual results. If you look at the IOL consideration in post-vitrectomy eyes, the bare bug is determining the axial length, especially in eyes which has silicone oil tamponade. And second is awareness on the choice of an appropriate intraocular lens to be implanted, power to be implanted in the eye. If you look at the difficulties in axial length measurement,
The connection is gone.
errors in axial length measurement can occur. There may be overestimation of the axial length, especially in eyes with silicone oil fill, and underestimation in axial length if you're dealing with a patient who has a macular pathology in the form of macular hemorrhage either because of diabetic retinopathy or the presence of an epiretinal membrane. And surprisingly, if you are using an optical biometer and you're dealing with a patient who has to undergo a phaco-vitrectomy and he has a bullous rhegmatogenous retinal detachment, some amount of underestimation in the axial length measurement must be there because of the thick, viscous subretinal fluid that fills the space between the retinal pigment epithelium and the neurosensory retina. Your measurement of the axial length is again compromised by the slowness of sound in silicone oil. And in addition, if you're operating too late in a patient who has had the silicone oil filled for too long, you will have emulsified silicone oil and multiple interfaces which again impedes the measurement of your axial length. You may be having a suboptimal silicone oil fill where there is a space between the posterior meniscus of the silicone oil and the surface of the retina where your axial length measurement may not be optimal, or you might have your patient may have an eye like the last one shown here with the anterior chamber filled with the hyperoleon and a mature cataract, and your burden is increased further if he has been operated elsewhere and you do not know the viscosity of the oil that has been put in the eye. The ideal situation would be to have all patients who undergo vitrectomy with or without silicone oil tamponade have their biometric recording before performing the posterior segment procedure. The same can be archived in the hospital and a copy given to the patient in case he has to go elsewhere for his cataract extraction. And you can always measure the axial length. The ideal would be, like what Dr. Kumar said, to invest in an optical biometer since it gives you a definite idea for a definite axial length measured from the surface of the cornea to the retinal pigment epithelium. But if you do not have an optical biometer and has to use an ultrasound biometer, then there are real challenges, and I'll give you a few tips on how to get around the situation, although it is not the ideal situation. If you are using an ultrasound biometer to measure the axial length, you all know that the velocity of sound in the thick silicone oil is much less than that in the normal vitreous. You have poor retinal echoes because of the slowness of speed of sound in the vitreous cavity, and because of the presence of emulsified bubbles of silicone oil, you may have shifting reduplicating echoes. And it is necessary to convert the apparent axial length that you may get on your machine to the true axial length, making adjustments with the speed of ultrasound in the silicone oil. If you have an old type of technology in the ultrasound biometer where you cannot reset your velocity gates depending upon the viscosity of the silicone oil that you are using. You calculate your the axial length, and then you make a correction by using a conversion factor for the velocity of sound in the standard silicone oils that we use, that is 1000 or 1300 centistrokes, or rarely 5000 centistrokes of silicone oil. Ideal again would be to use the optical biometer. And if you know the velocity of the silicone oil that is present in the vitreous cavity, and you have a little more advanced ultrasound biometer where you can set your velocity gates to the viscosity of the silicone oil, then you can calculate the conversion factor without using what is available by using this formula given here, and then add everything together to get the true axial length and use it to calculate your formula. You can reset the gate such as given here. But what do you do when you have an incomplete silicone oil fill and there is space between the posterior meniscus of the silicone oil and the surface of the retina? In this situation, always, if you are using the biometric calculation, always have your patient sitting up so that the posterior pole is covered with the silicone oil, and the fluid that is there present, which is either the liquefied vitreous or the posteriorly circulated aqueous, can settle to the bottom of the vitreous cavity. In certain situations when all your knowledge does not give you a good axial length, it's impossible to obtain an axial length. The silicone oil removal should be done in such an eye. Have the axial length measured either intraoperatively using a sterile probe, or postoperatively. You do a stage procedure when you do the silicone oil removal first and then the cataract surgery. The worst option is to use the fellow eye axial length or use a standard power IOL, which is not necessary in the present case scenarios. Intraoperative biometry for intraocular lens power calculation using a sterile probe. The procedure is done at the following the silicone oil removal. Also gives very good predictable target refractory errors. You can also use the intraoperative retinoscopy for IOL power calculation using a variety of formulas taking into account the aphakic refractive error. The Lanchelev's, McCool, or various other formulas are available. And this is another subset of patient where the axial length errors associated with vitrectomy for macular diseases in patients who have a macular pathology and a thickened macula. If you're using an optical biometer, you're only measuring, if you're using an ultrasound biometer, you're measuring only up to the internal limiting membrane. You can use an optical biometer and get an true axial length reading. But in case you're using an ultrasound biometer, you measure up to the internal limiting membrane, and then you measure the retinal thickness and add it to your axial length to get the true axial length. So in these eyes, the compensation for the underestimated axial length can lead to a better postoperative refractive outcome by implanting an IOL about 0.5 diopter less than that IOL targeted for emmetropia, or what I said earlier, to calculate your true axial length by adding the increased central retinal thickness to your measured axial length. What about eyes who have undergone a gas tamponade? In this situation, when there is a non-expansile gas bubble filling the vitreous cavity, it pushes the lens iris diaphragm forward, and there is a little IOL tilt that occurs. When even after the gas has resorbed, you find that some amount of tilt still persists, and the patient usually has a myopic shift postoperatively. This can be corrected by to achieve a target postoperative refraction of plus 0.5 suggested to minimize the postoperative refractive surprises in this group of patients who have undergone a gas tamponade. What about scleral buckled eyes? In these eyes, there is an apparent lengthening of the globe by about 1 millimeter or so, but this lengthening is basically confined to the posterior segment. And if you use the standard IOL formulas and correct measure the IOL power and implant in the eye, you can have a myopic surprise in the postoperative period. Also, the take-home message is that you wait at least up to a period of about 3 to 6 months after the buccal procedure to allow the globe to optimize its axial length. The lengthening caused by the buccal stabilizes by this period of time, and then have the patient undergo the cataract procedure. Now that you have calculated the axial length in patients who have silicone oil in the eye, the decision to whether to remove the silicone oil or retain it in the eye. If you have a compromised posterior segment, most of us retain the silicone oil back in the eye, which is bad both for the surgeon as well as for the patient. And in this cases, you have to bear in mind that the refractive index of silicone oil is different from that of the vitreous and almost similar to that of the intraocular lens that you implant in the eye. So when the back of the lens comes in contact with the silicone oil, that acts as a single unit and it neutralizes the power of the back available in the back of the lens. So postoperatively, you may have a hyperopic shift in the refraction, and in these patients in whom you are going to retain the silicone oil, and you should implant, the rule of the thumb is to implant an IOL, which is about 3 to 8 diopters more than your calculated power. But please explain to the patient that they will be having a myopic shift when they undergo silicone oil removal at a later date. You can also use this formula taking into account the refractive index of the silicone oil, the vitreous, the axial length measured in millimeters, and if in patients who require almost a permanent silicone oil tampon. Now let us look at the accuracy of the new generation IOL formulas in vitrectomized eyes, and it is seen that most of the new generation formulas give a very predictable target refraction. If you're using the traditional formula and your eye has an axial length of more than 26 millimeter, the Bangkok axial length adjustment gives almost the same results. Constant optimization in patients who undergo a combined procedure is more beneficial than using an optimized constant for your IOLs. So in conclusion, we are dealing with a subset of patients who have very compromised posterior segments, and we should do everything that is in our hands to give them the optimal vision in the postoperative period. I thank you very much for your patient hearing.
Thanks a lot, Dr. Meena. It was quite a exhaustive topic, and you opened up a virtual Pandora's box. There are a lot of things that have to be discussed. We will postpone the discussion till Nazneen finishes the talk. Nazneen is going to summarize the entire session. See, most of the talks that we have covered today, basically, you can have an entire instruction course on each topic. So we have compressed it to 85 minutes. So there are certain limitations, and I wish we have some time for discussion. What happened, Nazneen? Yeah, no, you take your time. No, take your time. Single camera recording, and we should be uploading it at the earliest possible opportunity. So all sessions that have been presented here will be available on the website. I mean, this has been going on for the last couple of years, so we are following the same trend this year too.
Thank you, Arup sir, for giving me the opportunity. I'll just quickly tell a few take-home points. So, no financial interest. So, biometry literally means measuring the eye, and it is the method of applying mathematics to biology. It's an essential step before cataract surgery, and the aim of biometry in most, but not in all cases, is Interoperative. So, we have evolved much from a rehabilitative surgery that cataract surgery was to a refractive customized surgery that it is nowadays, and the patient expectations have also reached sky high. So the take-home messages are good preoperative evaluation is very important. A good biometry machine, we have been talking on the optical biometry, the choice of the appropriate IOL power calculation formula, and to take special care in special situations like astigmatism, post-vitrectomized eyes, post-refractive surgery eyes, and very small and extremely long eyes. It is important to counsel the patient. It is important to communicate the patient, identify the patient's expectations, what the patient desires, particularly independence at risk condition, have a clear understanding, have a clear dialogue with the patient, and document everything. So the preoperative considerations are take a thorough history, do a proper examination, optimize the ocular surface, and look for other things like dry eye and meibomian gland disease, tackle them if they exist. Take more than measurement on more than one device, use more than one IOL power calculation formula, do a good patient counseling, and choose the proper IOL trabeculectomy, aphakic, pseudophakic, post-refractive, and a host of other conditions. So coming to toric IOL calculations, monofocal toric IOLs provide a superior visual acuity. So the anterior corneal measurements can be done by keratometry or topography. As for the posterior corneal astigmatism, can be measured either by a direct measurement by like gallery or Cain topographer, or via the Barrett toric calculator, or others like the Physial toric calculator. So the Barrett toric calculator was devised by Graham Bell. It is very accurate and it is available free at AACRS and APACRS websites. The Cain toric formula also is said to give results as good as the Barrett toric calculator. The Physial calculator incorporates the Abulafia formula and can be used with any other standard toric calculator. So intraoperative biometry, those who have it, it measures the eye's astigmatism in the aphakic state in the intraoperative phase. If you land up with a residual astigmatism, then how to tackle it, whether to rotate the IOL, whether to exchange it, or to go for a refractive surgery. You can go to the astigmatism fix site, and that will tell you how to tackle the situation. We have the Barrett RX formula. So the take-home messages are toric IOLs are the standard of care for astigmatism. Aim for multiple readings, use multiple instruments. Posterior corneal astigmatism is of course an important consideration. Ensure that the corneal astigmatism is regular. Use a good marking device. Use advanced toric calculators. And do not forget, last but not the least, the surgeon-induced astigmatism, that you can use the Warren Hill this Excel sheet, and you can calculate your own surgically induced astigmatism. Coming to secondary IOLs, they have a host of indications, like IOL exchange can be required for a wrong IOL bar, for a subluxated IOL, for an opacified IOL, and for other situations. So of course we know that the implantation of IOL in the bag is the best, and the next is the sulcus implantation. In the bag and scleral fixated, we can use the usual calculators for sulcus implant and iris fixators. Calculate for the bag and adjust the power accordingly as given in the Warren Hill site. So these are few nomograms that you can use. For an anterior chamber IOL, you can roughly reduce the power by 2 diopters, and for these are some other nomograms that are available. For piggyback IOLs, calculate the total power needed for emmetropia and divide the power into bag and sulcus. You can also use this Holiday IOL Consultant, which is available at hicksoap.com, which uses 7 parameters like the axial length, K reading, white to white, the lens thickness, and other factors. If you don't have it, then it's not a problem. This is a rough guide. If you have a myopic error, multiply it by 1.2, and if you have a hyperopic error, multiply by 1.5, and that would be the IOL power required in a case of a secondary piggyback IOL. You can use certain other nomograms like the Gill's nomogram, but the Barrett RX formula is are at risk of greater risk of
सबको बचाएंगे खुद से ये वादा कर लिया है
postoperative hyperopia
जब जोर लगाएगा टीवी हारेगा देश जीतेगा इंडिया जब जोर लगाएगा टीवी हारेगा देश जीतेगा.
Or you can use the Barrett Universal 2 along with your optical biometry, or you can use the Hill RBF formula. The latest one is also the LADA's super formula, which uses artificial intelligence. So Barrett's Universal 2 is one of the most accurate, and there is no need for adjusting the axial length. It is available, and the Hill RBF method is based on the artificial intelligence. The Hill RBF calculator is available, and it caters to extreme high myopia, and it provides calculations for IOLs from +5 to -5. The latest super formula uses artificial intelligence and crowdsourcing, which means that we can use thousands and even millions of data points to achieve unprecedented accuracy in our IOL power calculations. Posterior staphyloма is a challenging situation. It must be recognized preoperatively using an ultrasound, and optical biometry is a better option. For short eyes, there are a multitude of problems, like patient could be non-ophthalmic, there could be a shallow anterior chamber with a thick IOL, and you have a confusion as to which IOL power to choose. So optical biometry is a good choice, and few other options have already been discussed. Posterior segment situations are again challenging situations. Vitrectomized eyes, they have fragile capsule, weak zonules, and silicone oil filled eyes have been discussed by ma'am. Their silicone oil eyes, they can cause change in the refractive status of the eye and can lead to errors in the axial length measurement. So there are several options like do the biometry before the silicone oil insertion, or do it after the removal of the silicone oil, or do it in the other eye. These are few of the options. Optical biometry, of course, is the technique of choice for measuring the axial length, and you can use the formula like Barrett Universal 2 or the image-superior verifying IOL, EVO-IOL, or the Cain or the Ladder super formula. For post-vitrectomy eyes, the IOL power formula which provide good results are Barrett Universal 2, the EVO-IOL, the Cain IOL, and the Ladder super formula. For post-refractive surgery cases, biometry after refractive surgery is challenging, and standard IOL power calculations can result in post-operative refractive surprise. Standard keratometry does not apply. It is difficult to calculate the effective lens position, and the traditional formulae do not work. So do a corneal topography, a shim plug topography, measure the anterior and the posterior corneal surface, and Holiday 2 is one good option. It is available at hicksoap.com. So this is the IOL power formula at a glance. To sum up, thorough history and a good examination, good patient counseling, opt for optical biometry where possible, take multiple readings, and appropriate IOL power calculation formula is the key to success. Audit your results, learn from mistakes, discuss with seniors, take proper special precautions in difficult eyes. Thank you.
Thanks a lot, Dr. Nazneen. See, Dr. Those of you who came late, she has summarized all the talks that happened before you came. So, if just before I conclude, I would like each speaker to give one take-home message for the audience. Kumar, if you have just to convey one point.
I think an optical biometer will become a necessity.
Optical biometry is the way to go. Prashov?
For toric IOLs, take multiple readings. If you have only a single instrument, if you have multiple instruments, take readings from multiple instruments. Always make sure the ocular surface is okay, and follow the basics.
So basically you need to have a primary instrument and secondary instrument for each parameter that you measure, the corneal measurement that you make. Okay, Ramesh?
For if you have a PCR or a drop nucleus during surgery, don't rush in and put in a lens. Refer to a person who has got experience in these eyes, and tell the patient that half the surgery has been done and the remaining half will be done later. So that will give you far better results than trying to manage on your own. If you're experienced and you have the tools with you, you can certainly go ahead.
Meena?
Please have the axial length and the IOL biometry done for all your patients who undergo posterior segment surgery before the initial surgery itself. That will solve a lot of issues.
And the final concluding point I gave the introduction would be that keep your eyes and ears open to the latest that is happening in the field. A lot of devices are coming up, comparative studies are happening. So my practice pattern keeps on changing every year. Whatever I told, the pearls that I follow today, next year may be different depending upon my experiences and what is latest that is published in the literature. So thank you so much for being here in the early morning. We had a very good attendance. Unfortunately, we could not take up questions because of paucity of time, but I think we all had a fun time. Thank you very much to all my speakers.